So much for joining us. My name is Dr. Kendall Ward, and I'd like to thank you for coming to what is the second in our series of educational webinars that we're holding this month, in the month of June. So today we're going to talk a little bit more about the solutions to the opioid crisis. And in particular, we're reaching out to you, providers of healthcare services, today to talk about the ways that the changes to the XWaiver can help you save lives of people in the state of Florida and in your communities. Next slide, please. So first, a little bit about me. My name is Dr. Kendall Portal, and I'm the Director of Data Analytics and Strategy for Project Opioid. In addition, I'm also an Associate Professor of Healthcare Informatics at the University of Central Florida. Next slide, please. So just to get started, I just wanted to tell everybody a little bit about Project Opioid and what Project Opioid is. Project Opioid is a statewide coalition of business, faith, and philanthropic leaders that work together to confront the overdose crisis and save lives in their community and around the state of Florida. So if you look at our little wheel over on the right, you can see that these business leaders work with people who are already in the field, people such as yourselves, the providers of healthcare services. And what we're really trying to do is bring the people that aren't currently engaged in healthcare to this issue. So what we're really trying to do is bring individuals who can make changes in their community, educate them and empower them to really change the front line on the opioid crisis, from the emergency room, from the physician's office, to their places of worship and to where they work. So Project Opioid just takes a different perspective on how we can help individuals and work with our providers and our frontline in our communities. Next slide, please. And I know that I am not telling this crowd anything that they don't know, that COVID-19 has created a significant challenge in the mental health of the individuals in the state of Florida. We are seeing just a huge spike in the number of people that are dying from overdoses, primarily by opioids, and then primarily really by fentanyl. So between 2019 and 2020, we've seen a 31% increase in overdose deaths in the state of Florida. That's a huge number of individuals that are being impacted. And for the first time in Florida history, fentanyl has outpassed alcohol or benzodiazepines as the #1 drug in descendants, according to the medical examiner. So really, the opioid crisis, the overdose crisis, has changed significantly since the COVID-19 and the introduction of fentanyl into so much of the drug supply in the state of Florida. So really, that's why we're coming together and making this such a priority, to educate providers such as yourself, to educate our leaders on how they can get involved, what they can do to help stem the tide of individuals who are losing their lives unnecessarily. Next slide, please. So without further ado, I'd like to put a huge thank you out to our sponsors of our webinar series, our June webinar series, Central Florida Cares Health System, which is located here in Central Florida, LSF Health Systems, which is located in North Florida, and then the Southeast Florida Behavioral Health Network, who's located in South Florida. Without these partners, we would not be able to get all of this really important information out to you, out to the general public, and out to the community leaders that we're targeting with our webinar series. Next slide, please. So just a reminder, we do have some upcoming webinars. We have one actually this evening that will be held with Dr. Erin Wool, who is joining me today, as well as Dr. Pamela Carbiner. And so I hope you can all join into that one, where they're going to be talking about what individuals really need to know as they are moving forward and as we are dealing with this crisis in our community. So if you have any questions, please put them in the chat, and where there's going to be time for questions and answers later with Dr. Wool. And I look forward to any questions that you have. So next, I'd like to introduce our speaker, Dr. Erin Wool, who is an emergency room physician for the Veterans Affairs and a wonderful advocate for individuals who are suffering from opioid use disorder, and really a major proponent in the state of Florida on the use of NAT. So Dr. Wool.
Okay, Well, I appreciate the introduction. Thank you very much, Kendall. I'm going to go ahead and share my screen here and see if we can get this to work. All right. Okay, how are we doing?
Perfect.
Okay, my name's Dr. Aaron Wohl. I'm an emergency physician by trade. Probably over the last 10 years, I became a big proponent for treatment of opioid use disorder because of the number of patients I saw coming into the emergency department. Interestingly enough, emergency medicine has sort of been on the forefront of treating opioid use disorder because we've been some of the first providers throughout the country to actually engage and start treating patients with medication-assisted treatment in the emergency department, and then trying to bridge them to outpatient care and follow-up. So I always start off with essentially stating, it's not why the addiction, but why the pain. We always ask, what's the trauma, or where is the trauma? And many people don't understand that addiction for most people, and of course I understand the use of substance use disorder, but frankly, sometimes addiction just rolls off the tongue a little bit better. And we really need to understand that addiction isn't a problem. It's more of a solution. If people are in pain, suffering from anxiety, fear, depression, rage, sadness, there's really nothing wrong with wanting to get out of that pain. So oftentimes they've turned to opioids as an oblivion. If we look at substance use disorder from a state of compassion as opposed to judgment, we can better understand that the person is in pain and really just trying to get out of it. We also have to understand, of course, that substance use disorder is biochemical, highly dependent on dopamine and serotonin. It's in the tissues. And if we encourage wellness and community and faith leaders to bring patients together, to have community, to diminish loneliness, it really helps these patients suffering from substance use disorder. I just want to really quickly go through that. Mainly these issues, this pain, this trauma is usually labeled adverse social determinants. That's a good vocabulary word for most providers to take away. And these are the declines in education, employment, wages, worsening childhood trauma, marital decline, and concurrent mental illness that have really occurred over the last 20 years in the United States with the loss of factory jobs. Nobody can graduate high school and have a good retirement any longer. And so millennials now are suffering a great deal of anxiety, a lot of depression, and with their lack of good employment and wages, they're suffering from a cumulative disadvantage and some degree of hopelessness. And so when people are hopeless or helpless, they engage more likely in risky behaviors, such as excessive alcohol use and substance use. I also want you to take away adverse childhood experiences. This is abuse, household challenges, and neglect. You can see that basically, if you have 4 or more adverse childhood experiences, you're 11 times more likely to take part in IV drug abuse. I won't go through the entire slide, but you can see how powerful negative experiences and negative adverse childhood experiences are to the trajectory of addiction. We often state that addiction is a pediatric disease. 9 out of 10 people with substance use started in adolescence. 11% of adolescents in the US develop substance use disorder. Again, that's about 1 in 10 before they reach 18 years of age. What about those patient issues that have been made worse in COVID? We talked about the negative social determinants, financial income loss, loss of employer insurance. A lot of folks have suffered issues with housing. They're living more with triggers because of the isolation. There's been less community support. They've had a disrupted drug supply. So where they've normally gotten their illicit substances, they found a new one, and that might have a different concentration of substances. And then healthcare access has been somewhat worse in many ways, but in some ways better through telehealth and relaxed legislation regarding telehealth. There's also been decreased access to harm reduction, which is Narcan or safe syringes, not in Florida particularly, but in other states. And then those patients usually that do worse with COVID are those that take part in smoking and heavy marijuana use and vaping, and there's some more susceptibility to lung injury. And so that's been somewhat made worse by COVID, of course, and has probably contributed to some of the increase in deaths. I want to encourage all the providers to understand that recovery doesn't mean abstinence any longer in 2021. We usually just state that it's a process of change to improve folks' lives, their health and their wellness. We encourage them to live self-directed lives and strive to reach their full potential. Recovery should not mean complete cessation, but really a laudable goal is just markedly diminished reduction in the use of these illicit substances. If they bounce back and have a little bit of positive, illicit substance in their urine, we're definitely disencouraging you to not treat them. A lot of folks have just kicked them out of treatment, and these patients are human beings. They're going to make mistakes. The disease process makes them think differently and less logically, and we shouldn't be saying, oh, if they've gotten into any illicit drugs, then we stop treatment. Obviously, it's a complex brain disease. This is long-lasting effects on the structure and function and rewiring of their neural networks. I want to encourage you that this is not a Project Opioid initiative. Medication-assisted treatment is, even from the National Academies of Science, Engineering, and Medicine, this is March 2019, essentially opioid use disorder saves lives. And mainly, I'm going to read just one of these conclusions, which is MAT is effective across all treatment settings studied to date. If we as healthcare providers are withholding or failing to have available all classes of FDA-approved medication for the treatment of opioid use disorder in any healthcare or criminal justice setting, we are denying that patient appropriate medical treatment. Sometimes that's otherwise known as substandard care, and some people would call it malpractice. Again, I'm not saying that MAT is the only thing that they need to be on, but we really need to encourage much more broader use of MAT for many more patients, the majority of patients, to help stabilize their brain chemistry and make them more susceptible to improvements in behavioral and mental health treatment. Everybody kind of will say, and even within providers, you'll find people say, well, really, Aaron, we're just kind of changing one addiction for another. And I want to encourage you that it's not really a semantic argument. Remember, addiction is continued use despite negative social consequences, also usually associated with some dishonesty over use. When we put them on a prescribed opioid agonist, such as methadone or buprenorphine, they become dependent. And dependence shows no acquisition harms, injection harms, or street drug harms. I always say all of us are not addicted to coffee or caffeine. We're all dependent on caffeine because nobody's really frustrated with our caffeine use. Nobody's frustrated with our blood pressure medicine use. And the analogies really work quite well for substance use disorder as well. They can have a normal functioning life as opposed to when they're suffering from addiction. They're suffering a lot of manic and risky behavior. They're exposing themselves to injection harm and street drug harms. I also want to explain that abstinence rarely works, really for less than 10% of people. The alternative to medication-assisted treatment is not a drug-free patient. It's a continually relapsing patient, and relapse has a high association with death. Why do we use medications? Because they work. MAT makes the recovery process much safer. We've already talked about real changes in the brain, a sincere rewiring of the brain. They lose their prefrontal cortex, logical functioning and logical decision-making. Their more primitive brain takes over, which is fight or flight. 80 to 90% of folks relapse without using medication. So it increases treatment retention. There's an 80% decrease drug use and crime. And then most importantly, a 50 to 60% decrease in all-cause death rate. And so how does the most effective MAT work? Well, Obviously, you understand it occupies the opioid receptors. It relieves their cravings. It normalizes their brain chemistry. It prevents their withdrawals, and it does not impair functioning if dosed correctly. And that dosing is definitely done on an individual basis. There's no negative effects on intelligence, mental capability, physical functioning, or even employability. You can still be on these medications and work in numerous jobs. One of my patients that's a big success story is climbing poles as a lineman, an electrical lineman, and he's up on tall poles, and he does use buprenorphine daily. The medications associated with medication-assisted treatment or medications for addiction treatment. Most folks are familiar with naltrexone. This is a long-acting opioid antagonist. It blocks all opioids within the system. It's a lot of times used in abstinence therapy, of course, and it's really for individuals who usually have a lot of social support. These are physicians that have gotten into trouble with substance abuse, lawyers, airline pilots, NFL players. It does work well for that group of folks who have enormous resources for treatment and holistic therapy. But there is a high dropout rate for those of lesser socioeconomic status. And what happens is that lowered tolerance can contribute to an increased overdose rate because this medication only lasts about 28, 29 days. So if they're on it, they've had no opioids. If they relapse, they're much more sensitive to the respiratory depression than the euphoria that they previously got. And so they're at a high chance of overdosing. Methadone, many of us are familiar with, long-acting full opioid agonist. It can be dangerous when associated with other drugs, and it has led to some overdoses. And then methadone clinics essentially require the patient to come to the clinic every day at odd hours. And this is very, very difficult for those patients that have professional, family, or caregiving responsibilities. So we come to buprenorphine. Buprenorphine is the drug that the XWaiver was designed for. This drug, buprenorphine, is a partial opioid agonist. It was designed to be used in office settings, and unfortunately it hasn't caught on. Many of us believe that's because of the XWaiver restrictions. This medication is unique in that it has the most receptor affinity of all other opioids. So it binds to the opioid receptors stronger than any other opioid. So it actually does create a blocking effect. It's much less abuse prone. It blocks those more abuse prone opioids and illicit opioids. And so therefore it's uniquely suited to treat opioid addiction. You can actually give the patient a week's worth of medication and not be fearful that they might overdose because of its protective effect. It's very safe in pregnancy, lower risk of overdose for mothers, fewer drug-drug interactions, and these moms can receive the treatment in an outpatient setting. Why is it so safe? Because what happens is it's a partial agonist. You can, on the lower aspect of the graph here, you can see that no matter the dose, essentially you can give a very high dose, and this white line is buprenorphine, and it never reaches breathing cessation up here at the top. If you saturate the mu receptors, that's the opioid receptors, with all other opioids, full agonists such as morphine, fentanyl, hydromorphone, oxycodone, even hydrocodone, you can get breathing cessation. But buprenorphine, even if the patient took all of their doses, it does not cause breathing cessation. If it is mixed with alcohol or benzos, yes, it can lead to overdose, but we're finding that much more rare than we previously thought. In France, when they increased buprenorphine prescriptions, the heroin overdoses precipitously dropped. They repeated this in Baltimore, Maryland, and had very, very similar results. The red is the heroin overdoses, the dashed line is the buprenorphine patients. And then you can see here the effectiveness. This is the percentage of patients that stayed in treatment for a year. So methadone, 74 to 80% stay in treatment for a year. Buprenorphine, or the buprenorphine naloxone combination, which is called Suboxone, has 60 to 90% effectiveness. And then naltrexone when you ask how long many of these patients stay in treatment for a year, it's only 10 to 21%. Again, good for some patient populations, not good for most of the patients that we're seeing in emergency departments and community health centers.
Dr. Wool, can I ask a question real quick?
Yeah.
How do most people in Florida and the United States get on buprenorphine or Suboxone right now?
Okay, so that's really an excellent question. That's really the crux of this talk, because frankly, what did they do before these waivers had been released, or the restriction on the XWaiver had been released? What would happen is let's say they were in an emergency department. The patient would come into an emergency department. Oftentimes, most of the time, the majority of the time, that patient would be discharged home with medications to sort of prevent their withdrawal symptoms. So anti-nausea medicines, some non-steroidal anti-inflammatories for pain, and we would add some adjuncts on. And then we would expect that patient to go home, not relapse, and find treatment on their own. But what we started to realize is that it was our job as emergency physicians to place these patients on buprenorphine from the emergency department, write them for about a week's worth of medications, and discharge them with a bridge or a peer support specialist to an outpatient addiction treatment center that uses buprenorphine and or methadone. So that's the whole thing we've tried to establish with Project Opioid, is making those connections between the providers in the community and the hospitals. Because of what's happened with the XWaiver, essentially any and all physicians should be able to write for that initial dose of buprenorphine, 3 to 5 days, and be able to bridge that patient safely to an outpatient treatment facility. Let's say a family member wants to get their loved one buprenorphine. Dr. Corteliu, you said, if I'm a family member and I want to bring my son in and get him treatment, I would look specifically for addiction treatment centers that utilize medication-assisted treatment as the primary basis for their treatment. And the reason we're saying that is because it's the gold standard now. The literature has proven itself over and abundantly. Yes, they need counseling, they need mental health therapy, they need behavioral health therapy to teach emotional resilience, but that's as an adjunct to medication, and together they work ideally. So if you're a provider and you're sitting here and you're going, man, I don't want to do this XWaiver to write for buprenorphine. I don't want to go and spend 8 hours. Thankfully, what has happened is the federal government with the Health and Human Services has changed the requirements. Did they get rid of the XWaiver? No, it's actually still here. But any provider who wants to write less than 30 patients at a time, this is very, very important. If I write a patient for 7 days and they utilize that prescription, while they're on that prescription, I've gone down to the ability to write for 29 patients. Once that 7 days is expired, I've gone back up to 30 patients. So you can see that most healthcare providers in the acute care or hospital care setting, or even the primary care setting, who don't want to continually treat that patient, they don't consider themselves experts, although I would encourage you to become one, it's not hard, is you can treat 30 patients on a rolling basis. You will never reach 30 patients in an acute care setting. And so what happens is if you want to write for these medications and write for prescriptions to go home with, you can just search buprenorphine waiver notification. What you'll see is this website, and you just start applying. It's very, very simple. You put in your MD, your license, your Florida license, and your normal DEA registration, and you submit it, and you carry through with that process. And what happens is SAMHSA sends you an XWaiver DEA without the training requirement. You do not need the 8 hours. You still need the XWaiver, but you don't have to take 8 hours of training. Let's go back. Let's say you're interested in medication-assisted treatment as a provider and you want to give and start treating patients on a part-time basis, which is what I'm doing as an emergency physician. When I'm off, I'm working in an MAT clinic. Well, then you need the 8 hours of training. So there's really no excuse to not engage our patients who are suffering from opioid use disorder and at least offer them buprenorphine. How to dose it is a little bit of a different lecture, but I'm just trying to encourage you all as providers about the importance of medication-assisted treatment in the paradigm of treatment and promoting recovery. And then, yes, together when we address, buprenorphine is an MAT, and MAT addresses health, we also need to address home, community, and then purpose. And so that's really what these webinars are trying to promote, is starting with MAT, healthcare counseling, behavioral health counseling, then promoting a home for the patient, promoting community to diminish loneliness and isolation, and then assistance with job finding and work to develop purpose. A lot of folks would say, okay, well, we've gotten them on MAT and I've sent them to a provider. I want you folks that might not be addiction providers to understand that MAT, it's a myth when we say it shouldn't be encouraged for long-term use. It really should be. The research shows that patients need to be on it at least 1 to 2 years to have the greatest rates of long-term success. There's definitely no evidence to support any benefits from cessation. And in fact, MAT for some patients could be indefinite. Why is that? Well, because they have a real trouble dealing with those social triggers that they're involved in, those negative social determinants, and how well they deal with emotional resilience. And so if they're not really improving there, they might need to be on the medication for life. Remember, they're dependent on it, they're not addicted to it, and it's keeping them alive and keeping them functioning.
Dr. Wohl.
Yes.
Bring up one thing before we move on, and because you mentioned that buprenorphine is safe in pregnant women, and I know that from my research, this is a major area of people that are at risk. So what would you say to an OBGYN that doesn't want to get involved, but maybe needs to be able to do prescribe?
I would strongly encourage them to understand the importance of MAT for their patients and the baby or fetus. And I would encourage them to just send in that notification, get their waiver without training, and then encourage their patients to start buprenorphine. They can go ahead and give them a buprenorphine prescription, ideally for 3 to 5 days, and then encourage the patient to find treatment within the community. And that's, again, a bridge. The state of Florida is working on making that more robust, those bridge connections. But if I was a OBGYN who really wasn't interested in long-term treatment of my patients with this medication, at least give it to them to make them safe from the time they leave your office to the time they reach the addiction treatment provider, which can be a number of days, a weekend, that sort of thing.
Great.
So that's what we envision with this new, basically pulling back of the restrictions for the XWaiver. We really hope that primary care doctors, really no one, even hospitalists, these are doctors that work in hospitals and admit and discharge patients. Upon discharge, they can, of course, now write for a prescription for the patient to go home with and be safe until they reach the outpatient treatment provider.
Great, thank you very much.
You're welcome. And lastly, just the financial case for MAT. If we get patients on buprenorphine and treat them with buprenorphine, the treatment overall is approximately $13,500 a year from numerous studies. Compared to no addiction treatment at all, the patient just sort of continually circulates and comes back into the acute care setting, emergency departments, health centers, community health centers, and the cost to our communities is $31,000. So, it's our responsibility as physicians, it's our ethical responsibility to offer this medication that saves lives, diminishes fatality by 50%. And I can only encourage you to do it by just putting in buprenorphine waiver notification and signing up. If you need education or assistance with dosing, you can of course reach out to Project Opioid and reach out to me, or you can just basically start to research it yourself. It's not hard. It's a very, very safe drug, and it really should be part of all providers' repertoire of treatment options. And that's pretty much it. I wanted to encourage naloxone prescribing for these patients as well. And just remind everyone that is a provider that you can write or prescribe naloxone for anyone at risk for having or even witnessing an overdose. That's called third-party prescribing. And there's Florida law protects you from criminal or civil liability if you wrote it for these persons in good faith.
And I also want to mention that you can go to projectopioidorg and request naloxone, and you can advertise that to your patients, to anybody that you feel is at risk. And we will send you naloxone for free of charge.
I'm going to stop my screen share here, folks.
Good. Really great questions for you while you were talking, Dr. Wohl. So the first is, if a provider isn't ready to do MAT, doesn't want to prescribe MAT, what can they do to help the situation?
If they don't want to prescribe MAT, I'm sorry, Dr. Corteliu, do you mean in general at all, or?
In general at all.
I would strongly discourage any provider from taking that stance, sincerely. Again, if you've written for a pain medication such as Percocet or Vicodin, you are writing for a more dangerous medication than buprenorphine is. Where everybody gets concerned about buprenorphine is they've heard that, oh, well, if I give it to them at the wrong time, it can precipitate withdrawal. Well, that's true. But if you just understand that all you need to do is calculate with what's called a COWS score, C-O-W-S, their level of withdrawal, you can then initiate them on buprenorphine if that COWS score is 8 or more. And so it's really quite simple. And again, sincerely, every provider in the hospital setting can give a dose of buprenorphine. You do not need an x-waiver for that. But if you want to prescribe your patient to bridge them bridge them and get them to a safe place, a safe addiction provider, you should at least write them for 3 to 5 days with this new waiver notification.
That's great. Thank you very much. It's great to hear that it's such a safe drug. So, and that kind of leads into the next question. So what can providers do to give pain relief without prescribing opioids? Okay.
Well, I would encourage any provider that wants to, first of all, thank you for asking that question. We should all try and keep patients opioid naive. In other words, if that patient has never had opioids before, we would really try and give all options other than opioids, specifically for back pain, headaches. You know, a lot of providers give opioids first. There are numerous websites online that are labeled ALTO. That's called Alternatives to Opioids. And you can look these up from incredibly well done websites that encourage you to use other pain modalities for treatment. And it's usually a multiple modality treatment plan. So anti-seizure medication for nerve pain, anti-inflammatories together in conjunction, muscle relaxers. You can even get into alternative treatment modalities such as acupuncture, physical therapy, yoga, Pilates, wellness. We're really trying to get patients to move, to increase their serotonin and their dopamine stores so that they can continue with life, in much more of a normal manner without needing these medications.
Thank you for mentioning the Altos. I wanted to go ahead and plug one of our webinars next week that is going to be on Altos and how providers can use alternative therapies during that webinar. So that's a great segue. Another question that we got is, I mentioned early on that we've seen such an increase of fentanyl in our drug supply and in the number of people that are overdosing and dying. So what do you suggest from a provider's perspective we can do to help educate people to understand what fentanyl is, how dangerous it is, and how it can wind up in their drug supply?
We just need to continue our public service announcements. Don't mean it to make it sound easy. It's simple, not easy. But we need to encourage patients to understand that, you know, whatever source they're getting from, whatever supply chain they're getting it from, almost 85% of it contains fentanyl, and sometimes at a very high potency. Fentanyl is 100 times stronger than morphine. Fentanyl is much, much cheaper to make than heroin. A kilogram of wholesale fentanyl is about $2,800 for somebody to synthesize in a lab via organic chemistry. They just make it together, put it together. Whereas if you cultivate the poppy seed to develop heroin and develop a kilogram of heroin, it's about $65,000. So everybody can see why when fentanyl hit the streets in 2013, you know, users liked the high. It's a very, very powerful euphoria. And then dealers really turned to it as well to increase the need and desire for their product. I mean, it's a free market, and that's what they're doing. Now, unfortunately, fentanyl has found its way into supplies of cocaine. So folks who are thinking that they're safe from overdose are snorting cocaine and overdosing on fentanyl because they had no idea that the cocaine was laced with fentanyl. Whether that's being done intentionally by dealers or accidentally, we don't really know yet. We don't have a ton of literature on it, so it's hard to say.
Yeah, I've noticed that too in my research, that we're really trying to figure out why fentanyl and how it's gotten into all of this drug supplies during the pandemic in particular. So from a provider's perspective, are there things that we should look for in our patients, risk factors, things that we should be concerned about before prescribing MAT or before prescribing opioids?
Certainly before prescribing opioids, young persons are at risk, younger age, previous substance abuse, mental health issues. Those are definitely some risk factors. Family history of addiction, in fact. And again, previous use, previous substance use disorder diagnoses. Those are really the most concerning that we utilize. There's numerous websites, of course, that can make suggestions as far as finding and better identifying these patients that are susceptible or susceptible to ongoing opioid use. And again, the other issue is just limiting the supply of opioids that you dispense. Everybody used to basically write for 20 or 25 of these pills, meaning Percocet or Vicodin. And what's happened is we've recognized that even after acute surgeries, the maximum number of days that most people require pain medications, opioid pain medications, is only 3 days. So we really should only be writing for a 3-day supply. Are patients going to have some pain? Absolutely they are. But we really need to also, as providers, change the paradigm of what we're really gaining by giving pain medication. We do not treat for zero pain any longer, or a 0 out of 10 scale. We say we were treating for functionality. We want you to be able to get out of bed, to be able to ambulate about your house, and that's about the extent of it. We don't need much more than that. We don't want you to be out of pain completely. You're going to have some pain, and most patients only use 3 days of these pain medications. So there's a lot of strategies to encourage less opioid use.
Thank you very much. Yeah, I think we have seen in the literature the number of MMEs of opioids being prescribed has gone down significantly, but there's definitely still a lot of prescription opioids out there. We mentioned earlier fentanyl and it be getting into the other cocaine supply, et cetera. Would it be appropriate for someone who has encountered fentanyl in this way to start an MAT program?
If they've become dependent on the heroin, or they feel like they're withdrawing, or they have more cravings, essentially, if they've developed a substance use disorder associated with that fentanyl, then yes, I would encourage MAT training. But of course, MAT initiation. But of course, MAT is not really for that patient that's accidentally exposed to fentanyl and even has an overdose. We would, of course, encourage treatment for their cocaine use disorder or stimulant use disorder, but that's completely a different sort of lecture. But I would not encourage just anybody that's gotten exposed to fentanyl via cocaine use to be initiated on MAT. This is for patients that have severe withdrawals, that have a very difficult time stopping it, that are surrounded by triggers, and we're trying desperately to keep these patients alive and stabilize them. I do have a really good question. I'm sorry, Dr. Cortelyou. I see it up here. Let me just read this one really quickly. Is it best practice for the pregnant woman to be inpatient to be started on buprenorphine, or can this be done through OB office settings? So the question is, can you initiate a pregnant person on buprenorphine for pregnancy in the outpatient setting? The answer is absolutely yes. They do not need to be inpatient. There is some discussion. This is a little complicated, but when you prescribe buprenorphine, you can prescribe just buprenorphine, which is Subutex, or you can prescribe the tamper-resistant buprenorphine, which is Suboxone. It has naloxone in it, which is a reversal agent. And there's some discussion that pregnant moms should not be given Suboxone because of that naloxone component, in case they had some absorption. I don't really buy it. I'm not really a proponent of saying that. I would definitely encourage just starting them on buprenorphine alone initially. And it can certainly be done in an outpatient setting. I know I keep saying, go ahead and Google this, but you can look up PDFs on home initiation of buprenorphine. It's very, very safe, and it's being done all around the country. And so the patient does not have to be in acute withdrawals in the office setting. You can give them a prescription and educate them on when to initiate the buprenorphine and how to do so. And you can do that definitely as an outpatient.
That's a great question. Thank you so much for whoever asked that. So we know that pregnant women are a particularly vulnerable population. What other vulnerable populations are out there that physicians and providers should be looking at?
Certainly, those patients between 18 and 35 years old are our highest risk for overdose. Those patients utilizing opioids on a daily basis, they're not only susceptible to overdose or fatal overdose, of course, they're susceptible to HIV, hepatitis C, hepatitis B, and then, of course, endocarditis, or very bad abscesses throughout the body. And that is from injecting with dirty equipment and exposing their bloodstream to bacteria. So, numerous harms just outside of overdose. And again, it's usually the high-risk patients are those that have been suffering for, a year or more, that are 18 to 35 and have had previous overdoses as well. Sadly, if a patient has a near fatal overdose, their life expectancy is they have a 10% mortality in the next year following that overdose. So we've really got to latch on to these patients that have suffered overdose previously and encourage them to start getting on medication to treat their illness, and definitively to have their family members and friends carry Narcan around them as well.
Yeah, one of the other questions we just got was, what if you encounter somebody who's has been using for a year, obviously, but is not willing to go into MAT, doesn't want to start buprenorphine? What can you as a provider do to help that person?
So you can definitely, number one, educate them on harm reduction strategies. We can't force anybody to take medications. We can't force anybody to take any medical therapy. That's essentially unethical. And, you know, we really need to quote, we say it a lot in addiction therapy, meet patients where they are, which is approach them when they're ready. Offer it to everybody, but, you know, approach and engage when they're ready. If they're not ready, tell them that you have an open door to start them on these medications, explain to them why you want to start them on the medication, explain to them the risks of not being on the medication, and then you should definitively go over harm reduction strategies with them. A lot of providers are nervous about this. I usually have some slides in my presentation, but I was trying to make it shorter today. And, you know, that's educating on safe needle use, cleaning the sites, you know, using clean needles, how to clean it's called their kit, which is their equipment to use opioids, IV, and really educate them on those harm reduction strategies, and then definitively get them at least some doses of Narcan to carry around. And of course, you can send them to outpatient treatment centers. But again, I would say send them to an outpatient treatment center that uses MAT. And why do I keep saying that? I keep saying that because still to this day, about a third or more of addiction treatment centers are not utilizing MAT. They're still on this abstinence-based model, which we feel is dangerous for patients and really substandard care. Does it work for some individuals? Absolutely. The 12 steps we still encourage as far as building community and building support. But we do not encourage just abstinence alone. You're going to find those amazing stories where patients stopped cold turkey and did well. And so MAT is not for everyone. But the majority of patients we want to keep safe, keep alive, and get them onto MAT in some shape or form.
Wonderful. Thank you very much. And, you know, we've mentioned some particular sites to Google, but what treatment, or excuse me, what training is available to providers who want to do more in this area?
You can definitely go to SAMHSA's website, SAHMSA. I can't remember how to spell it. SAMHSA's website. You can look up buprenorphine courses, buprenorphine education, and you can take a very brief course on the use of buprenorphine. It doesn't have to be an 8-hour course. Of course, I would encourage you to try and get there and do that 8-hour course, but there's limitless resources for patients and for providers. Let me see, I actually might have, yeah, there's another good resource I've suggested is FORE, that's the Foundation for Opioid Response Efforts. And there's numerous little mini webinars that any provider can take. It's completely free, and educate themselves and their staff on the use of these medications. Additional resources, as I mentioned, is SAMHSA, CMS, and the American Society of Addiction Medicine, which is called ASAM, ASAM.
Is there a provider community? Are there people that they can talk to, peers, individuals they can work with?
Yes, I'm actually one of 5 peers that go out and lecture to other providers in the state. And we work for FADA, which is the Florida Alcohol and Drug Abuse Administration. I might be saying that wrong, but you get the idea. And yeah, we educate and go out to certain sites and educate folks and providers specifically on how to use buprenorphine, how to initiate patients on it. And that training is essentially free for anybody that wants to go to one of these trainings. But you can reach out to FADA and actually get one of us to come and train a group of your professionals that you want to put together, and we'd be happy to do that. Again, there's about 6 providers throughout the state, and we can go all over the state.
That's great. So they could just go to FADA's website and find the information there?
Yes.
Okay. And Amber is telling me that she has put the links in the chat. She is ahead of us. So there's links to all of those resources that Dr. Wohl just mentioned in the chat. So I know today our main audience is providers and other healthcare professionals, but I wanted to see, Dr. Wohl, is there any advice, information you would give to someone who has a friend or a family member who's suffering, who's addicted, who's overdosed before? What kind of information could you give them?
Yeah, I'll answer a question at the same time that I answer this, your question, Dr. Portaliu. Somebody did ask, has it been mentioned that MAT isn't just RX, meaning prescriptions? And they stated it includes CBT as well, ? CBT is cognitive behavioral therapy. I hope that I made it relatively clear. It doesn't always come across, and I apologize for that. That MAT is medication for addiction treatment. What we are encouraging is medication to be the anchor or the mainstay, and absolutely have other cognitive behavioral therapy, emotional trauma therapy done in addition to that. But if you don't have the patient on MAT, a lot of times their brain chemistry isn't stabilized, and they do worse with just CBT alone or cognitive behavioral therapy alone. I also want to say this, and again, this is not to just encourage medication use alone, but there is a misconception that if counseling is not available, that you should not place the patient on MAT. And I want to say that that is absolutely not true. If counseling is unavailable, please place the patient on MAT. It still saves lives. It still works relatively well. Ideally, we want concurrent behavioral health, cognitive behavioral therapy, but that always cannot be obtained quickly or efficiently. And I'm still asking to put them on the medication. But I'm glad the question came up, because I don't want to endorse medication treatment alone. If the patient is desperate and that's all that they can receive, then please still grant it to them and encourage them to use it. But of course, this all works best when we affect the spirit, the emotions, get to the pain. Again, not why the addiction, but why the pain. So where is the trauma? And then deal with that trauma via CBT or other emotional and sort of talk therapy and counseling. Any modality seems to work, and we don't have any specifics on which one works best.
Yeah, that's a great point, and I'm so glad that question was asked. One of the issues that we dealt with yesterday, in our first webinar, was really looking at holistic care. So if you get a chance, go back and go to projectopioid.org, and we really talk a lot about how people can get access to other kinds of treatment. Again, that holistic treatment. So there's a webinar out there. I encourage you all to go and watch that as well. So I have one more question, and we only have about 4 minutes left. But Dr. Wohl, what would you say if there's somebody who can't afford to be on MAT? So if you have a patient in your office, but they just simply can't afford it, what kind of information or resources are out there?
Well, patients should be able to go to one of their federally qualified healthcare clinics in their community. That's what we're encouraging the managing entities and sort of the state to better fund. And they can find significantly decreased costs to these medications. If they're just on buprenorphine alone, the expense is really not what people have thought it would be. You can really treat a person for approximately $50 a month. And in some respects, we've got to say, that that's definitely a barrier to some, but not for most, and really encourage them to get on to the MAT and find options to get treated more fairly as far as the cost. You will find some unscrupulous physicians offering MAT at very high cash prices, and I would say please go somewhere else. Please search for another provider that's not taking advantage of these patients. They are out there. Yeah. I also wanted to say, somebody stated, please mention that if the patient isn't willing to do counseling, still it's unethical to withhold MAT. So again, if the patient isn't interested at all in counseling, still please offer them MAT, offer them harm reduction strategies. It still can save their lives, and one person matters.
That's a great point. And I also want to bring up one more thing, because I know some of the regulations changed around telehealth prescribing for MAT. So can you give us a quick update on that?
Yeah, telehealth prescribing for MAT has changed, and so the powers that be, essentially federally, used to require that buprenorphine be an in-person visit to initiate a person on buprenorphine. That has been relaxed. You do not have to. You can do telehealth initiation of buprenorphine now, which is fantastic. And however, methadone, still the initial appointment must be in person, but once the patient is relatively stabilized, they can even get sort of their continual treatment via telehealth. And of course, telehealth has made counseling and cognitive behavioral therapy much more accessible and really much more private for a lot of patients. They actually prefer the private setting and actually do very well in the comfort of their own home.
Yes, that's a great point. We've seen a great number of people gain access to behavioral health care through the use of telehealth. So we have about 30 seconds left. So I want to have a wonderful thank you to Dr. Wohl for joining us today and giving us such great information. Just if you have any interest, if any questions, please reach out to us at Projectopioid.org, or you can email me directly and I can put you in touch with Dr. Wohl. It's just Kendall at Projectopioid.org. So again, a huge thank you to our webinar series sponsors, who are the managing entities that can also provide the help that Dr. Wohl mentioned. So Central Florida Cares, LSF Health Systems, and the Southeast Florida Behavioral Health Network. So we are out of time. I greatly appreciate all of you joining us. If you have any questions, please let us know. And of course, join us for our webinars for the rest of this month.
Thank you, Dr. Cordelieu. Really appreciate your involvement and you moderating.
Absolutely. Thank you so much for your time.
My pleasure.
All right. Bye, everyone.
Bye.